Imagine treating a structural collapse inside your body by just popping open a tiny silicone tent.
Right.
I mean, it's an engineering marvel when you think about it. But what happens to that perfectly calibrated medical scaffolding when you introduce the unpredictable, high-impact physics of sexual intimacy?
Well, you introduce an incredibly complex clash of biomechanics and biology. The environment is just no longer static.
Welcome to another deep dive. We are exploring the non-surgical management of pelvic organ prolapse today, and we've got a really fascinating stack of sources for you.
We do. We're looking at clinical guidelines from pelvic and obstetric physiotherapists, medical studies on prolapse and pessary devices.
Yeah, and detailed literature on dyspareunia, which is the medical term for painful sex.
Exactly.
And we are taking all of this data to answer one highly specific question for you today. Can the mechanical shifting of a pelvic support pessary during intimacy alter internal surface pressures enough to cause a sharp localized pain?
It is a question that really forces us to look at the human body, not just as a collection of tissues, but as a dynamic structural system.
Right.
I mean, to really answer it, we have to start by understanding the architecture of the pelvic floor before we even bring a medical device into the picture.
Let's lay that foundation then. Because when we talk about pelvic organ prolapse or POP, we are essentially talking about a failure of structural support, right?
Exactly.
Picture the pelvic organs for a second, the uterus, the bladder, the rectum. They are held up by this intricate hammock of muscles and a network of ligaments that kind of act like suspension cables.
And over time, those suspension cables can stretch or they undergo trauma.
Like from childbirth.
Right. Pregnancy and childbirth are major factors.
Mm-hmm.
But it can also stem from chronic coughing, years of heavy lifting, or even just the natural decline in collagen production that happens with the drop in estrogen during menopause.
Wow.
When that hammock weakens, gravity just kind of takes over.
The organs physically drop or they bulge into the vaginal space. And the sources describe it as this really profound, heavy, dragging
It's
sensation.
very uncomfortable.
Yeah, and it can cause urinary or bowel difficulties simply because the plumbing, for lack of a better term, is kinked. The structural alignment of the whole system is completely thrown off.
Right. And when natural support system fails like that, the first line of defense is often to introduce artificial support.
Enter the pessary.
Exactly. That is the pessary. It's a removable device, typically made of medical-grade silicone, though sometimes they use plastic or vinyl, and you insert it into the vagina to provide a structural brace.
So if everyone's internal anatomy is slightly different and the severity of that organ drop varies from person to person, I imagine a one-size-fits-all silicone ring doesn't really work.
Oh, not at all, no. The literature outlines an entire catalog of pessary shapes designed for very specific structural failures. So you have the classic ring pessary, which relies on tension against the vaginal walls. But for a more severe prolapse, a doctor might use a Gellhorn pessary.
And that one looks kind of different, right?
Yeah, it's a flat circular plate with a stabilizing stem that sits right in the center. And then there are cube pessaries, shelf pessaries.
I even saw inflatable ones in the clinical guidelines.
Oh, yeah.
Like where the patient actually uses a little hand pump to achieve the right pressure. It's wild.
Those exist for patients who need maximum adaptability. But mechanically speaking, we can divide all these devices into two primary categories.
Okay, what are they?
Space-filling and supportive. So space-filling devices like the cube or the Gellhorn we just mentioned, they literally take up the entire volume of the vaginal canal.
To create a roadblock.
Exactly, to create a roadblock that prevents the organs from descending. But supportive pessaries, like the ring, are fundamentally different. They leave the center open, they just sit flush against the vaginal walls to provide outward tension.
It's like a tiny pop-up tent system for your vagina.
That is actually a really good way to visualize it. Yes.
But because a space-filling pessary literally plugs the canal, penetrative intercourse is impossible with those, right? It acts as a physical barrier.
All right, those have to be removed prior to intimacy.
But with a ring, the center is open. And you'd think that just solves the problem, but it actually introduces a new one, which is physics.
Yeah. The clinical guidelines are very clear in busting this myth that getting a pessary means the end of a patient's intimate life.
Because you can leave the supportive ones in.
Exactly. Supportive pessaries are specifically designed to be left in place during sex. But, acknowledging that they stay in place leads us to the reality of what happens when you introduce the highly variable forces of intercourse into a confined space, a space that is currently holding a piece of silicone scaffolding.
Okay, wait, let me push back on this for a second because I want to make sure we are visualizing the mechanics correctly here.
Sure.
If the ring is specifically sized by a doctor to sit completely flush against the vaginal walls, wouldn't it just move like with the vaginal tissue during sex? I mean, why would it cause friction if it's securely anchored in equilibrium?
Well, that assumes the vaginal environment exerts uniform pressure from all sides,
Yeah.
like it's locking the device in place like a tire on a rim.
Right. Is it not like that?
No, not at all.
No.
The vaginal canal is not a uniform PVC pipe. The research papers highlight this really interesting concept called vaginal pressure profiles.
Okay, let's unpack those pressure profiles. How do they even measure something like that? The sources mention studies using vaginal manometry, but what does that actually look like in practice?
So vaginal manometry involves inserting a specialized catheter,
Mm.
and it's equipped with multiple microtransducers.
Basically, tiny pressure sensors.
Exactly. Tiny pressure sensors located at various points along the device. And as the catheter is slowly pulled through the vaginal canal, it measures the resistance.
Oh, wow.
Yeah, it creates a 3D topographic map of the resting closure forces.
So it's mapping out exactly how hard the walls are squeezing shut at any given point along the canal.
And what those maps reveal is that the pressure is highly asymmetrical.
Really?
Yeah, the anterior wall, so that's the front, which sits right behind the bladder, and the posterior wall, the back, sitting in front of the rectum, they exert very different structural forces than the left and right side walls.
Huh. So the pessary is sitting in an unevenly pressurized environment even when a person is just completely at rest.
It is. It's sitting in this very delicate state of balance. Now, think about introducing penetrative intercourse. You are adding high-impact, directional, and highly variable shear and compressive forces.
So that equilibrium is instantly broken.
Instantly, the pessary experiences a mechanical shift.
Right. It might tilt. It might slide a millimeter.
Sure.
Or it might rotate out of its optimal flush position against the tissue.
Exactly. And when that happens, the entire surface pressure distribution changes completely.
Think of it like an O-ring inside a pressurized pipe. If that O-ring is perfectly aligned, the pressure is distributed evenly, and the seal holds. You don't even know it's there.
Right.
But if that O-ring twists slightly out of alignment, the dynamic changes entirely. Suddenly, all the pressure in that pipe is concentrated on a single tiny edge of the O-ring, which creates intense, localized friction against one specific side of the pipe wall.
That is the exact biomechanical reality happening inside the pelvis.
Mm-hmm.
When the pessary shifts, that firm medical-grade silicone is no longer resting evenly. It is digging its edge into a localized patch of tissue.
And the sources mention some very specific vulnerable spots where that concentrated pressure can be, frankly, devastating. For example, if someone has an episiotomy scar.
Yes, an episiotomy is a surgical cut made at the vaginal opening during childbirth to widen the space.
Right, and as that cut heals, it can form what the literature calls a skin bridge at the back of the vagina. And scars like that are densely packed with highly sensitive nerve endings.
They are.
So if a shifting silicone ring suddenly concentrates all of its surface pressure directly on that raised ridge of scar tissue.
The nociceptors, those are the pain receptors in that tissue, they are going to fire a massive alarm. It translates into a sudden, sharp, abrasive pain.
Ouch. The literature also discusses pudendal nerve entrapment.
Yes, that's another big one.
The pudendal nerve is like the main nerve pathway that services the entire pelvic floor, right?
Yeah.
So if there is already some underlying inflammation or entrapment of that nerve, the area is already hypersensitive.
Precisely. A mechanical shift of the device can compress those specific, already sensitized pathways. And it's not just momentary pain either.
What happens long term?
The clinical guidelines warn that over time, if you have this concentrated friction repeating in the same localized spot over and over, it leads to microscopic tearing, then grazing, and eventually actual ulcerations in the vaginal wall.
Oh, man. So we've basically directly answered the core question of our mission today. Yes, the mechanical shifting of a pelvic support pessary during intimacy absolutely can alter internal surface pressures enough to cause a sharp localized pain.
Definitely.
It just comes down to basic physics, you know? Variable force disrupting a resting pressure profile, which leads to concentrated friction.
The physics explain the mechanism of the shift, for sure. But if we stop there, we are missing half the equation.
How so?
Well, the severity of the pain isn't just dictated by the mechanical friction of the silicone. We have to look at the biological health of the tissue that's actually receiving that friction.
The terrain itself.
Yes, the biological terrain. The urology and continence care sources heavily detail a condition known as GSM, that's genitourinary syndrome of the menopause.
Right, which happens when estrogen levels drop, which is primarily during menopause, but also during breastfeeding or following certain medical treatments like chemotherapy.
Right, and when that drop happens, the vaginal tissue undergoes atrophy.
And atrophy profoundly changes the physical properties of the mucosa, doesn't it?
It changes everything, because estrogen isn't just a reproductive hormone.
It plays a critical structural role.
It dictates the structural integrity of the tissue itself. Without sufficient estrogen, the tissue becomes significantly thinner. It loses its natural lubrication, so it becomes very dry, and it loses its elasticity.
Okay, so let's think about this. If we take that exact same mechanical shift of the pessary we were just talking about, let's say it tilts 2 millimeters during intimacy.
Okay.
If it rubs against healthy, thick, well-estrogenized tissue, that tissue has enough elasticity and moisture to kind of absorb the shift.
Yes, exactly.
It might just register as minor pressure or mild discomfort. But if that exact same 2 millimeter mechanical shift happens against atrophic, dry, paper-thin tissue,
The friction coefficient just skyrockets. The tissue lacks the natural lubrication to let the silicone slide, and it lacks the structural thickness to cushion the underlying nerves.
Wow.
So that minor tilt. It now causes extreme sharp pain, bleeding, and rapid ulceration.
this brings us to what the sources refer to as the mixed picture of dyspareunia.
Yes, this is a huge challenge in clinical practice.
Because if a patient sits in a doctor's office and says, I have sharp pain during sex and I wear a pessary, I mean, it's a chicken and egg scenario. How on earth does a clinician untangle that? Is it the prolapse pulling on the ligaments? Is it the pessary shifting and causing friction? Or is it GSM making the tissue too fragile to handle normal movement?
The reality of interdisciplinary medicine is that it's rarely just one of those factors. It is usually all three acting together in this devastating neurological loop called muscle guarding.
We really need to dive deep into that loop because the sources frame this as the moment the body's natural defense mechanism actually becomes its worst enemy.
It really does.
Hmm.
So when that sharp, localized pain occurs from the pessary rubbing against the atrophic tissue, the nervous system sends a reflex arc from the spinal cord straight back to the levator muscles.
Those are the main muscles of the pelvic floor.
Exactly. And the brain subconsciously commands those muscles to contract.
Right, to brace for impact.
It's trying to create a splint to protect the injured area. But look at the architecture. The pessary is currently trapped inside that muscular splint.
Oh, I see.
When the pelvic floor violently clamps down to protect against the pain, it fundamentally alters the vaginal pressure profile even further. It literally drives the shifted edge of the silicone ring harder into the fragile tissue.
So the clamping down exponentially increases the surface tension.
Yes, which creates more intense pain, which signals the brain to guard even harder.
Oh, wow.
The clamping increases, the friction increases, the pain increases. It is a vicious self-sustaining cycle.
So a purely mechanical solution, like, I don't know, trying to fit a differently shaped pessary, that isn't going to break that cycle if the biological terrain is still fragile, right? Because the nervous system is still stuck in that guarding loop.
Exactly. You can't just change the hardware if the software is panicking. That's why the clinical guidelines stress a multimodal assessment. You have to map the exact nature of the pain.
Okay, what does that look like?
If a patient reports a burning sensation at the entrance, that strongly suggests tissue dryness and atrophy. But if the pain is deep and feels like intense pressure or acute rubbing, that points more toward the mechanical shifting of the device against the walls.
And the most fascinating intervention the guidelines propose for resolving this isn't necessarily surgical. To fix the biological terrain, they use local, low-dose vaginal estrogen.
Which operates entirely differently than systemic hormone replacement therapy, or HRT.
Let's make sure we clearly distinguish those, because I think that's a crucial point for you, the listener, trying to understand the pharmacology here. Systemic HRT involves taking a pill or using a patch that circulates hormones throughout the entire bloodstream to treat full-body menopausal symptoms.
Right. But local vaginal estrogen is highly targeted. It comes in a cream, a tiny dissolvable tablet, or even a flexible ring that releases a microdose directly into the vaginal canal.
So the systemic absorption into the rest of the body is negligible.
Negligible.
Yes. But how does a microdose of a topical hormone actually rebuild the tissue enough to withstand the mechanical friction of a pessary? I mean, the sources note it plumps the tissue, but what is literally happening on a cellular level?
Well, the vaginal mucosa is packed with localized estrogen receptors. So when you apply the topical hormone, Those receptors grab onto it and immediately stimulate cellular activity.
Like waking them up.
Exactly. They trigger the production of collagen, which provides structural density, and they stimulate angiogenesis, which is the formation of new blood vessels. That brings vital blood flow back to the area.
So it physically rebuilds the cellular wall. It turns the tissue from paper back into leather.
That's a great analogy. Over the course of a few weeks or months, the tissue regains its thickness, its natural transitate moisture, meaning its ability to lubricate itself, and its elasticity.
It effectively thickens the walls of our pressurized pipe, acting as a robust biological buffer against the rigid edge of the O-ring.
Yes. And once that biological terrain is restored, that slight mechanical shift of the silicone ring during intimacy is cushioned.
It doesn't hurt anymore.
Right. It no longer triggers the nociceptors.
Yeah.
And because there is no sharp pain, the brain doesn't trigger the muscle guarding reflex. The pelvic floor stays relaxed, preventing the intense compressive forces that trap the pessary. The entire ecosystem returns to a state of balance.
It is just a brilliant illustration of how interconnected our systems are. You cannot just treat a structural drop in the pelvis with a piece of engineered silicone and ignore the biological health of the living tissue holding that silicone.
You absolutely can't. You need the biomechanical understanding to evaluate the shear forces of the device and the endocrinological understanding to prep the tissue environment.
Let's bring all these threads together for you, the listener. Our mission was to uncover if the mechanical shifting of a pelvic support pessary during intimacy can alter surface pressures and cause sharp, localized pain.
And the evidence points to a definitive yes.
Pessaries act as this vital, non-surgical scaffolding to hold pelvic organs in their proper anatomical place when the natural ligaments fail. And while supportive devices like the ring pessary are specifically designed to allow for an intimate life, the physics of intercourse introduce highly variable forces.
These forces inevitably disrupt the resting pressure profile of the vaginal canal. The device shifts, it tilts, or it rotates. And when that rigid silicone edge presses into a sensitive nerve pathway or an old scar, it concentrates surface tension and generates a really sharp, localized pain.
But mechanics are only half the story. That pain is exponentially amplified if the vaginal tissue is suffering from genitourinary syndrome of the menopause. Thin, dry, atrophic tissue cannot cushion the shifting silicone,
Right.
which triggers a neurological muscle guarding loop, where the pelvic floor clamps down on the shifted device, driving it deeper into the fragile tissue and making the pain far worse.
The resolution requires treating both the mechanics and the biology, often utilizing local estrogen to physically rebuild the cellular walls and restore the tissue's elasticity and moisture.
It is just a remarkable look at how physics and physiology collide.
It really is. And, it leaves us with an interesting thread to pull on.
Oh, lay it on us.
Well, we've just spent this time exploring how a simple shifting silicone ring can so profoundly alter our internal pressure profiles, kicking off a massive cascade of localized pain, tissue friction, and subconscious muscle guarding, right?
Yeah.
It makes you wonder, how many other mysterious chronic pains in the human body, things we routinely dismiss as just getting older or stress, are actually undiscovered issues of basic physics.
Oh, wow. Just tiny shifts in structural alignment or surface tension, waiting for the right biomechanical adjustment.
Precisely. We often look for complex chemical diseases when the answer might just be structural friction.
What an incredible perspective to close on. Thank you for joining us on this deep dive. We'll catch you next time as we keep unpacking the fascinating mechanics of the world around us.